Greetings. Welcome to The View from the Summit. Today our guests are Dr. Jack Powell III of Georgia Bone and Joint and Mr. Zane McDaniel of the DePuy Company. And we're going to be sharing with you today a very interesting program on joint implants. Dr. Powell, the vision of Georgia Bone and Joint and the vision of the Surgery Center here at the Summit Healthplex, it all began with you. And as you've seen, the tremendous progress that has been made here over the years has got to bring to you a great sense of fulfillment. And we want to thank you for being our guest once again on The View from the Summit.
Thank you, Gene.
And also we have Zane McDaniel. Zane and Dr. Powell have worked together for many years. And Zane is a very important part of the surgical team that works with Dr. Powell on total joint implants. Zane is employed by the DePuy Company, Johnson & Johnson Company. And Zane, you work in the area of total joint implants also. And I'm sure that you've been with Dr. Powell as together you have performed many, many procedures. So tell us about you, about Zane McDaniel, and tell us about your work with DePuy.
I'm very proud. I think long-term relationships are very important, and I'm proud of the relationship that Dr. Powell and I have. Since 1982, I've been with Johnson & Johnson, and it's been a wonderful relationship business. One of the things I like about this business is that I'm able to work with surgeons, interact some with patients to help this operation be one operation lasts them all of their life. And we know that the implants only last a certain number of years, but as the implants have gotten better, the materials are improved, they're lasting longer and longer. And so I'm very proud that before Dr. Powell came, I worked with his dad, Dr. Jack Powell.
So you
Jr.
go back with the Powell family, and their interest in medicine for many, many years, don't you?
I certainly have, and I'm proud of that. While Dr. Powell III was off doing residency for spine, residency for hand, and residency for arthroscopy, we were here working, waiting.
So you were introduced to the Powell family through Dr. Powell Jr.
Yes,
Is that
sir,
correct?
I was. And Dr. Jimmy Thomason. We did broken hips together. And then once Dr. Powell came as a fellowship trained orthopedist, my specialty has always been the bone portion of that, whether it's broken or needs replaced. And so Dr. Powell and I began our relationship then. Has been a great partnership together.
Zane, tell us, how did you become interested in this type of work?
Well, I have a degree in hospital administration, and I was very fortunate to work at Piedmont Hospital in the 70s while I was in college. And I went to the assistant administrator there, Mr. Ed Tinneman, and said, I have to work full-time, and I think this is what I do. I'd like to work in the business and learn if that's what I indeed want to do. So I was very fortunate to work at Piedmont Hospital main campus downtown, and then graduated, worked full-time, went to school full-time, graduated on time, and worked for 2.5 years at Piedmont, then went for 5 years to Archbold Hospital in Thomasville, Georgia, another fine hospital. And then worked in the x-ray business, and after 5 years began looking around, and the joints have always interested me, and I'm very proud. As the implants have improved, we've learned and trained and modified things, and it's been great to travel with Dr. Powell, pioneer a lot of the new procedures, and then come back here and begin doing them for the residents of Newnan.
And Dr. Powell, you are known as one of the outstanding orthopedic surgeons, not only in this part of Georgia, but throughout our state and throughout, really throughout southeastern United States. How important is it to you to have someone with the knowledge and with the skills of Zane McDaniel at your side when you're doing a total joint implant?
It's been a great relationship. Like Zane said, we've been since '82. I came in '84, so I guess in '84 is when we started. When you first come back to a community that's not really done total joints, or done really my dad and others had done orthopedics here before, but the equipment had changed so much, we had to update it significantly. So it took a year or two just to get the appropriate equipment in here, and people like Zane and other people helped us get this organized. And over a period of time, we developed it's like it has to be a fine run machine when you're in the operating room. And it takes years to get that. And we finally have gotten that. And it took 5 years or so since '84 to get that going. And since then, it's just been wonderful.
So how long have you actually been doing the implants here in Newnan?
Oh, we've been doing the implants. We started doing total joints in '84, '85 and just worked through it. It took longer to do them at the time because we just didn't have the system together yet. But after a period of time, we have. And now we've reduced the operating time from probably 2 hours to 1 hour and 15 minutes on most total knees.
It really is a team approach, Dr. Tyre, where it takes people in the operating room, it takes a team in the office to get the patients approved and then to monitor them after surgery, as well as the team in the operating room.
Zane, share with us, if you will, what do you actually do? Now, you scrub and you go in the operating room with Dr. Powell.
Yes, sir.
What do you actually do during the procedure in the operating room?
There are technical representatives all over the country that assist the surgeon to, number one, discover what his choices are on routine patients, but especially on difficult patients, and to, ahead of time, communicate so that on the day of surgery, we have everything in place for Dr. Powell to choose from, depending on whether it's a routine case or a very difficult case.
Now, how do you find this out? Dr. Powell informs you of the type of procedure that he's going to be performing, and then you bring all the equipment that you need for the procedure to the operating room. Is that the process that you follow? So how long before the surgery do you actually know what's going to be taking place?
Generally, I'm working with Dr. Powell a couple of weeks ahead of the patient's scheduled date to first know what he uses routinely, to know if there's something different. We discuss those cases. I communicate with the hospital and I communicate with the hospital to bring in all of the needs.
Now, does the Depew company actually do the manufacturing of the equipment?
Depew actually manufactures the implants that are provided to the hospital sterile and that are exact fit to the design specifications. And there are a number of sizes, a number of choices that the surgeon can choose before the operation and during the operation. We call that interoperatively choose from which one. Then my role is to act as a liaison with the hospital and with Dr. Powell as a technical consultant. Any questions he might have. My main goal is in the operating room to work with the hospital personnel. We'll look later at the number of instruments. It's gotten to be a very complicated business. Lots of instruments for each patient that have to be properly sterilized, monitored by the hospital, and ready for the surgery. And so during the operation, my role is to assist the personnel giving the instruments to Dr. Powell. I don't scrub for liability reasons. I am just in the room to answer his technical questions.
Your mind runs along with his mind. You know really what he's going to need as far as an instrument is concerned almost before he asks for it. You guys have worked together for so long and have done so many implants. You know what he's going to need as he goes from step to step to step through the process.
Yes, sir.
And that's a team effort that we have, and that's where Zane sort of runs the back table. Like you're saying, you'll see a lot of the equipment that we use, but when you have 5 or 6 different sizes of knees and 6 pieces of equipment, equipment for each of those sizes, it really becomes a very complicated issue. But after a while, with Zane, the scrub nurses, and the whole team effort that we've tried to organize here, it really makes it a really nice run, streamlined machine. So it really works well.
Dr. Powell and Zane, I'm sure that our viewing audience is interested in the different types of joint implants that you perform. So would you identify some of the different procedures that you do?
Well, we have, of course, we do conservative management in the beginning, and we'll discuss that, I think, later on in the show. But really, we have the main prosthesis is called a total knee replacement. In the knee, you have 3 components. You have the kneecap, which is this component, which is turned upside down, but it sits there, and it's a part that sort of slides up and down this bone called the femur. And then we replace This component, called the femur, we replace the entire piece of the femur. We take out the whole, we make separate cuts, which you'll see.
Now you're going to show us in a little while how
we'll show you in a little while how to do that. And we take this and basically make different cuts to go ahead and make it, it has to be within millimeters for this to fit on perfectly. And then after we've done the femur, we do the tibia too, and this will take apart here. You've got a little piece of the stem where actually the tibia piece fits down here. We make a perpendicular cut. So it's really three main components, and that's called a total knee. That's where we place the kneecap, the distal end, the end of the femur, and the part of the tibia. There's also other types of knee replacements we do too, sometimes called a partial knee. It's one that's been around a long time. It's funny how things become full circle, but it's called a hemiarthroplasty, where we replace just part of the unicondylar knee. And what we do in that knee is we basically replace this condyle and a piece of this condyle, and that's it. The rest of the knee, the kneecap, and the other part of the knee is left alone. The problem with those that have been in the past is they had problems with loosening. They couldn't get good cement techniques to make them fit. So we started using these back in the early 80s. Then it sort of got where they went out of favor. Well, now they're coming back into favor. And we do have better techniques now, but I think it's still out on exactly how well they'll do. But the results are looking better, and it's a good knee to use too.
Well, Dr. Powell and Zane, how do you determine whether or not a patient is a candidate?
Well, let me finish. Before I get into that question, there's one other kind of knee too. Sometimes a patient will come in with a problem with the kneecap, and we actually will just replace the kneecap. And what we'll do is put a little piece of metal component here on the finger, but leave the joint otherwise intact, and then put a little plastic piece on the kneecap, and it basically articulates. And some people have just arthritis of the kneecap, and that's it. So we can replace pretty much different parts of the knee, use the entire knee, or do parts of it that we need to do.
So it's not necessary to have a total implant from
Not always. Most of the time we usually go to a total knee, because by the time you get them, most of the parts of the joint are destroyed. And if two of the parts of the joint are destroyed, it's probably better to go ahead and proceed with a total knee, because you hate to do a half operation and come back later and have to complete it and do the full knee, which is a little more difficult versus going in a virgin knee that's never been touched.
Let me ask you guys a question. Yes. Have you ever gotten involved in a procedure and you make the incision and you see what is there, and you've made plans to do one type of implant, and you get there and you see that, hey, I need to change the direction of the surgery? Do you ever have to do that?
With the techniques we have now, with the imaging we have with MRI and CT and X-rays.
No guesswork.
Well, it's not a lot. We pretty much know when we go and operate what we're going to do. Now, occasionally on a unicondylar knee, we're just going to replace part of it. You look up at the kneecap, and if it's really diseased, sometimes you'll go ahead and do the whole knee. But that would be the only issue, I think. Can you think of any other time, Zane?
Dr. Tyler, I was a Boy Scout, and so as part of this leading up to the operation, that's one of the things I'm really proud of, is there's almost no surprises in the operating room.
You're always prepared. Boy Scout motto, be prepared.
Yes, sir. And I hope that we have always done our homework and have not been caught without what we needed. Part of that lives at the hospital, and so that's part of the liaison with the hospital. And then it all falls to the communication between the surgeon and the rep to have everything that we need there on the morning of surgery. All he wants to see is a thumbs up. And buddy, you better have it.
So this gives the patients a lot of confidence.
Absolutely.
Knowing that all of the work has been done with all of the MRIs, all of the pre-operative studies that you do. You know exactly what you're going to do. You know the equipment that you're going to need to make sure the surgery is successful. You mentioned knee, but tell us about other implants as far as the musculoskeletal part of our body is concerned.
Can I just point out a couple of little things that I want the audience to understand? The total knee is the most popular operation in the total joint arena. Dr. Powell is going to discuss how he tries everything else, and your local orthopedist does the same, to not do total joint surgery. But if everything else has failed, it will give the patient great relief. We'll talk about what Dr. Powell does, but every surgeon does a number of steps leading up to the total joint surgery being the last resort. The surgery itself, since the total knees are the most common operation, and I'm very proud to say Johnson & Johnson is the #1 in the U.S. knee that's done. If I can focus just a minute, when you look at a side view of this implant, you will see its very particular thickness, that the goal of the operation is just to cut off thin slivers of bone. It's not to cut off the end of the bone at these ends. It's just to replace small slivers of bone that have the nerves embedded in it, and then replace them, resurface them, if you will, with metal that has no nerves intact. And so that operation is why it's so predictable in the knees, and the majority of the patients, long-term studies have shown 95% better, 95% or better results at 10 years. Some of those studies go out as long as 20 years. But in Dr. Powell's hands, personally, since he's here with us today, and his partners, those results are even longer than the 10 years with the majority of the patients, not having to have another operation.
I know you're finding that our program today is very, very interesting, and we're going to continue with Dr. Powell and Zane McDaniel after this word from our sponsor. Welcome back to our program with Dr. Powell and with Zane McDaniel. Dr. Powell and Zane, let's talk about a patient. Let's talk about a patient who comes to you and says to you, I'm having some real difficult problems with my knee. And you begin that process of diagnosis, and so take us through the different types of treatment that you would recommend up to the operating room and the total knee implant.
Well, when you first see a patient with knee pain, of course, we're going to talk about the older generation. I guess I'm in that generation.
I'm in that generation.
58.
Zane hasn't made it yet.
I've got to check that clock.
But I can check that for sure. But what we're looking at now is a patient that comes in with arthritis in the knee. It's not an athlete that has a torn meniscus, something like that. So I'm going to sort of go down that road, how to treat an arthritic knee. Well, the patient first comes in, they're saying they're having knee pain. Sometimes during the day it hurts when they walk. Sometimes at night they're having knee pain, and they're just wanting some solution. The first thing I tell them, I say, we don't treat x-rays, we treat the patient. So no matter, I've got a lot of patients walking around with really bad looking x-rays that are doing fine without any surgery. So we do everything we can to avoid operating, because I've always said orthopedics is a practice where you can make people live a more comfortable life, but you don't really extend their life longevity except unless they have a complication from surgery. So we're very careful about doing surgery unless they're to the point that they just can't live with that knee. And I let the patients, pretty much every case I do, I let the patient tell me they want the surgery.
Let me interrupt you. Let me interrupt you for just a moment. I think what Dr. Powell has just said really sets Georgia Bone and Joint apart from a lot of other medical practices. You treat the patient. And
we treat the patient, and it's them having the problem.
That's right.
And I like to let them make the decision, because it's not like heart surgery where you've had a heart attack and you've got coronary artery disease that you absolutely have to have the surgery. Orthopedic surgery is something that's basically making someone live a more comfortable life and living a more excitable life and fun life. So that's what we're here for. So when a patient comes in with a knee that has swollen in the knee, the knee's been hurting them, we usually examine the knee and see exactly where it is. And a lot of times you can tell by the knee just the way it feels where the arthritis is. I'll normally take an x-ray of the knee at the time and see exactly what the x-ray appears to show. And then after I've taken the x-ray, I normally will start out with just simple things. I think the first thing you can start out with is exercise program. A good exercise program, it's amazing someone with arthritis and keeping the muscle tone and building this quad muscle up here, how much help it will help the patient. And it's something they just don't need to do one day. They need to make it part of their daily routine. So we discuss that in detail. As we get older, unfortunately, we lose about 1 to 2% of our muscle mass per year. So when you start hitting that 50, 55 age range like all of us, then of course you're going to start losing muscle mass. And of course when you lose muscle mass, you lose strength in your leg. So it's very important to work on exercises. So we'll start with an exercise program. We'll also talk about drinking fluids, good diet, of course, weight loss. Those type of things do make a big difference too, and just a healthy lifestyle. And then also we'll talk about taking anti-inflammatories. Occasionally if they've had a real flare-up of the knee, I'll go ahead and put them on a type of anti-inflammatory like ibuprofen, Advil. We have multiple choices there. But I don't like to keep any patients on long-term medication as far as an anti-inflammatory, because it can affect your liver and kidney and other areas. So I usually tell them to take those in spurts. Like they have a real flare-up, take it for 2 or 3 weeks, get that flare-up under control, and then go ahead from there and just continue with their lifestyle. Also too, I tell them There's some nutritional medicines you can take too that will help rebuild the articular cartilage. There's something called glucosamine and chondroitin sulfate. It's called Bioflex on the shelf, or also cosamine DS. And those type medications are just basically over-the-counter medications, do help rebuild the articular cartilage, some studies are showing. So I'll suggest them to try that for 2 or 3 months and see if it helps them. So after we've been through the basic that, I usually let them go at that time and say, well, this is the situation, this is what you've got, and then we'll start talking about some of the other things you can do down the road on the next appointment. And usually if they come back, then sometimes, unless they had an acute situation initially, an acute flare up the knee, I will suggest maybe a cortisone injection to them. And the way the cortisone helps me is it lets me know to tell me if it's an arthritic problem within the knee, or is it something extracapsular or something mechanical that's giving them trouble. And if they get better with the cortisone, that's saying basically there's an arthritic problem, orthopedic arthritic problem. And the other thing we'll do too, there's a new thing out called Suparts. There's multiple companies that make it, and it's a lubricant that we'll actually use in the knee. So after they've done the therapy, they've done exercises like I asked them, we've done cortisone, we've tried the nutrition, we've tried the weight loss, then if they continue having trouble, I'll suggest maybe let's try something called Suparts. And there's some others out too, but the one I've lately used is Suparts. And it's a lubricant that you put in the knee, and it actually helps the knee move better. It helps the articular cartilage in the knee, and sometimes they'll last a year or two. And a lot of patients, I've been very happy with it, and 85% of the patients are getting some relief. And what we do is we do 5 shots for 5 weeks. And everyone says, oh, the needle's going to hurt me. But really, after you've done 1 shot, they get used to that, and the shots are really not that bad, and we can do them very quickly. We spray a little medicine on there to freeze the skin when we give the shot. And the Suparts has been very helpful too. And I've had a lot of patients just maintain on that, and a year or 2 later, they'll come back and get another set. Well, if we've been through all these different components of conservative management, and they come to me and say, Dr. Powell, I'm just no fun. And I basically tell them is if it gets to the point that your knee hurts you or your arthritic problem hurts you to the point that life's no fun living, then I think it's worth taking a few small risks to go ahead and consider having a total joint. And then we'll go down that road discussing the total joint and go from there.
Zane, would you like to add to that?
Yes. So I think, Dr. Powell, to summarize, you've tried everything conservative, and when those fail, the only thing left is the total joint as a knee replacement. But that choice is up to the patient when.
Absolutely. I tell the patient the first visit, if they even mention the word total knee, I says, I've got a lot of people walking around with bad looking x-rays. And if we can do well with all these conservative managements, you don't need to have a total joint. And I let them ask me. I tell them at the beginning of initial appointment, if you let me know, you'll know when you want this total joint. And if it's that to the point in your life when you want it, then we'll consider doing it.
Well, I hear both of you saying it's very, very important for the patient to be involved in making that ultimate decision.
Absolutely.
Once again, patient controls their healthcare destiny. We've affirmed that time and again.
Dr. Tyra, if I may, I want to tell you, traveling all over the state, there are centers that advertise a lot that are trying to get a lot of patients to come to them. And it appears often that those are short-circuited to say, I have heard the term, we can do your case tomorrow. The thing that I'm very proud about, and especially for you residents of this local area, both in the Fayetteville area and in the Newnan area, that this team of surgeons at Georgia Bone and Joint are very conservative and leave those decisions to the patient themselves. And I think that's a great difference that you're fortunate to have in this community because of Dr. Powell initially and all of his partners who operate the same way. The decision is the patient. The time to do the total joint as a last resort is up to the patient to make that decision. Now, Dr. Powell, if you've told the patient that, can the patient wait too long? Is there a point, a lot of patients in this community have had it. Some of them are excited and are on their way and happy as they can be. Others have said, oh, it was terrible, I'm not going to get the other knee done. And a lot of the audience today have heard both. So is it possible that you can wait too long for a total knee after you have told the patient that's the only choice that we have left, failing all the conservative treatments?
I think when the problem ones that I see are the ones that develop these significant deformities of the knee. We call them varus and valgus deformities. And what happens is, over a period of time, you can see certain people walking around with the knee bent in like this. That's called a genu varum, or going out genu valgum, which is bow-leggedness.
Or my granddaddy called that knock knee.
Knock knee. Well, knock knee, that's it.
Right.
And so if they get to the point that they really can, sometimes they can get such a deformity that can be makes the surgery much more difficult. So at that time, sometimes I will say, well, your deformity is getting a significant amount, where it's going to be difficult for me to correct it in the usual manner if you don't go ahead and have something done. So those patients, I'll just tell them that and just say, this is your options, and it may get to the point that it's going to take a much bigger operation to correct your deformity if we don't go ahead and do something. And I've still had people walking around with their knock knees and they're happy as they can be. So it sort of depends on the individual and how much pain they're having.
Our time for this segment of our program is over, but let me share with our viewing audience some good news. Dr. Powell and Zane have agreed to do another program, and the program that they do is going to be very, very interesting, because they're actually going to be involved in the process of showing you how they work in doing a knee implant. But I want to thank both of you for being on The View from the Summit, and we look forward to the next program. And I want to thank you, our viewing audience, for taking time to let us visit with you today. And remember, you control your health.